And today's training is really going to focus on part one, really focused on kind of the assessment and identification of eating disorders, kind of at intake. And today we're really going to spend time talking about if you are the primary outpatient provider, what are some interventions and just considerations as you're working with someone who is struggling with an eating disorder. Just a brief introduction about me. So I currently work as a licensed clinical psychologist in a university athletic department. But I've worked in a variety of different settings. So previously, I've been at a university counseling center, at an outpatient clinic for eating disorders, and in graduate school, worked as a milieu house counselor at a partial hospitalization treatment for eating disorders. So really have worked across a variety of different settings with a variety of different access to resources and interdisciplinary care. I always like to share that I very much operate from an integrative theoretical perspective, but I'm very much grounded in attachment framework. And so really thinking about internal working models and relational needs and how eating disorder behaviors are very often just an attempt to get a relational need met. I also integrate other third wave modalities that we'll be talking about today, ACT, DBT, as well as some of Neff's self-compassion work. I want to be really clear that this is just one perspective, that there are other evidence-based treatment for eating disorders that have lots of success. And so really just thinking about this as a sampling and a very non-comprehensive list of interventions and things to consider. This is my therapy dog, Della. She's an almost 3-year-old golden doodle, and she and I trained to have her become a therapy dog, and she comes to work with me about twice a week. So she is part of the treatment team for some of the individuals that I work with. She's really wonderful at offering grounding and just additional support and validation in only a way that a dog can. And so before we begin, I just think it's really important to recognize that this is an area where everyone has their own relationship with their body and eating. No one, no one can go around and say that they don't have a relationship. We all live in a body and we all live in a culture that very much has some pervasive unhealthy cultural norms. I often, will work with individuals and not to invalidate or dismiss how hard substance use recovery is. And there's a lot of comorbidity between eating disorders and substance use. But eating disorders there's a unique challenge in that the goal isn't to abstain. The goal is to figure out how to establish a relationship with food where they are able to nourish and thrive and socially connect with others. Because food is such a central part of connection and celebration in a way where someone struggling with a substance use disorder or addiction, the goal, right, is more harm reduction and abstinence for some people. And so they might be able to avoid certain triggers. And this is just different with eating disorders because we have to eat multiple times a day to live and survive. And there are a lot of mixed messages about what healthy eating even is or what's desirable, and just wanting to acknowledge that. Because we all have our own relationship with our body and our own experiences and family messages, as well as societal messages, we walk into the room with our own biases, experiences, and perspectives. And I think in this area, just like any other area of identity or presenting concern, it's important to be curious about how are we walking in a way that is treatment facilitative or treatment interfering and seeking consultation and or supervision as needed. But to just recognize that it's just very layered and complicated, and just the importance of self-reflection and being aware of. I do like to just kind of get a pulse check on the audience and get a sense of where people are at. And so this is through Mentimeter. So if you want to, I invite people to engage and answer this question. You should see instructions to join at menti.com using the code 983 89496. So I'll just have you all take a moment. I'm going to just make my screen smaller here. Um, and just wanting to get a sense of, you are meeting with an individual and you see on their intake paperwork that they are coming in presenting with eating or body image concerns. What are some of your initial thoughts, concerns? What do you feel most challenged by? Physical health and medical stabilization is the big one, especially on, I think can be especially hard as an outpatient provider, how receptive they are to treatment, avoidance, not having enough knowledge or skill, determining if it's a true eating disorder or OCD or both. Yes, there's a lot of comorbidity, our own perception of ourselves, how to balance safety, family support is big, transference, family engagement, building rapport during intake, working with binging along with borderline. And my hope in doing this is also just to validate and normalize that um, everyone has concerns and challenges, and there's a lot of overlap here. Wanting to, make sure you're using the right language, connect with the individual, establish rapport while also prioritizing safety, managing your own relationship with your body and own internalized maybe beliefs and impact of culture. And so my hope today is that we'll go through a few different interventions so that you're walking away feeling a little bit more equipped and confident to be able to sit with an individual. So as I mentioned earlier, the part one of this training really focused on kind of the diagnostic criteria and kind of really getting kind of at that assessment and different questions to ask at intake to get a sense of the severity of the eating disorder and behavior. And so we won't be really diving into that today. This is going to be very much an extension or, part two. But really wanting to just kind of briefly go over, the common eating disorder diagnoses in the DSM-5, and wanting just to make note that over the course of, an individual's illness, it's very common for individuals to have diagnostic crossover. So someone might, initially present with restricting subtype anorexia nervosa, but over the course of the illness, either, either at one point meet criteria for binge purge subtype, or might at some point meet criteria for binge eating disorder. I also think it's just really important to note that, and I could go on a whole thing about the diagnoses, but I won't, but just that oftentimes someone might not meet criteria for bulimia nervosa, but they might be engaging in binge purging, but maybe not to the frequency to meet that criteria. And so that a lot of individuals that we're working with are likely going to be diagnosed with OSFED or the other specified feeding or eating disorder. And the other thing I just wanted to make note of is I think body dysmorphic disorder is different than an eating disorder, but there can be comorbidity, just like there can be comorbidity with OCD and eating disorders, and that the kind of the experience of body dysmorphia is different than the distorted body image that somebody will experience, if it's with anorexia, bulimia, or OSFED. In that BDD is different in that there's typically a hyperfixation or emphasis on one specific body part, and then the body checking or repetitive behavior that they're engaging in is providing some temporary relief, similar to kind of obsessive compulsive disorder, whereas the distorted body image in an eating disorder is primarily going to be a very kind of global dissatisfaction with body shape, size, or weight. And there's a Venn diagram and there can be an overlap. So someone can have both distorted body image, primarily with an eating disorder, and experience body dysmorphic disorder with some with a specific body part and engage in body checking behavior. And there's overlap in the body checking behavior that an individual with BDD might engage in, as well as an individual with an eating disorder. But just wanting to name that, I think it's very common, at least for some of the individuals that I work with, that I think body dysmorphia has become maybe some common language that more individuals anecdotally that I'm meeting with are using to describe their experience. And I think it's important to assess, like what that experience is. But that I have found that in the last couple of years, it's often describing just that general sense of distorted body image and like negative evaluation of self. Um, and while you might have the experience where somebody is coming in with this being the primary reason, and it's on the intake paperwork. It's oftentimes comorbid with something else. And if we're not doing the assessment, we might not know kind of what their relationship with eating or body is. And that can then interfere with the treatment of the presenting concern. If that's depression, anxiety, or other pieces. So I want to invite you all today throughout the training to think of a specific case where eating and body image concerns have been a part of the presenting concern. This can be an individual that you're currently meeting with, or perhaps an individual that you've met with in the past. And just considering how you could apply the concepts or considerations discussed today, and then also recognizing, right, if there are things from today that you might want to adjust to like meet your client where they're at. And so just talking a little bit about eating disorder outpatient. In an ideal world, you might get a weekly 45 to 50-minute session. In a very ideal world, that individual could also work with an outpatient dietitian who specializes in eating disorder. And in a even more ideal world, that individual has had good experiences with navigating the healthcare system. I think the reality is that depending on insurance coverage, access to transportation, motivation for treatment, lots of different reasons, you may not have that weekly session. It's very hard, in my experience, if you're not already working in an office where there's interdisciplinary care, to find a dietitian who specializes in eating disorders. Who accepts insurance to have an individual be connected. And it's very often that individuals are coming in with negative or traumatic experiences in navigating the healthcare system, where they feel like they really have to advocate for themselves, or it's not uncommon for someone who is in a larger body to be told at their annual physical that they really need to go on a diet or cut out sugar or given extreme kind of dietary advice without any questioning or curiosity about their current relationship with food. And that individual might be engaged in a very vicious cycle of restriction or binging or over exercising. And just recognizing kind of the internalized fat phobia in the medical healthcare system. And so that can all seem very overwhelming when we're the kind of primary provider. And how do we provide support, help the individual advocate for themselves, and prioritize that physical safety piece? And so really focusing on kind of what is within our control as a provider. So establishing guidelines and boundaries, identifying shared goals, and assessing risk, both with suicidal ideation, non-suicidal self-injurious behavior, but also that physical medical risk that is related to eating disorder behavior. And so I think just to share some case examples, I think in establishing guidelines and boundaries, I have done this in the past with individuals who are coming in. I had one individual who was seeking outpatient treatment for the first time as an adult, previously had received higher level of care treatment as an adolescent, not by her choice, right? This was a parent's choice. So this was the first time that she was seeking treatment on her own. And I was very concerned because of she presented with very low weight and was reporting pretty high restrictive behaviors. That for her to engage in outpatient treatment, I would first have her, she would have to undergo like a medical evaluation to make sure that she was physically stable to engage in outpatient treatment. And so there is the NIDA website has a really good recommendations for like what does physically stable or medically stable mean for outpatient treatment in terms of, you know, kind of heart rate over, a certain amount, like resting heart rate, uh, blood pressure, and then really getting some lab work done to look at electrolytes, liver enzymes, and things like that. And so the individual that I worked with went to urgent care, got some blood work done, and she came back. She was medically stable enough to engage in outpatient treatment. And we established kind of a guideline and boundary that, given where her weight was, if we engaged for, the next 8 weeks and her weight trended down or at a certain point wasn't like trending upward to a more weight restorative kind of place to really increase kind of physical safety, that I would be giving her a higher level of care referral because it would be unethical for me to meet with her as an outpatient provider. And she really just wanted to kind of give outpatient a try. And it felt really important to try to meet her where she was at because there was some level of motivation. And I was concerned, right? Because she didn't have a whole lot of support kind of on the outside. And so part of what we did then was that we scheduled her sessions purposely kind of during lunch hour. And so she would bring in lunch to session as well. And so there was some accountability piece there. And we kind of had ongoing conversations around those guidelines and boundaries, and she was able to engage. And while it was slow moving at first, it worked well. Like the best decision to honor autonomy while also helping her kind of shift behavior kind of in that 1 degree kind of increment. I think it's also really important to identify shared goals. Ambivalence is really normal in this presenting concern. And I think it's very common for individuals to come in um, who really want to decrease the binging behavior or feeling out of control around food. Um, but when really getting a comprehensive assessment, kind of seeing the cycle of the restricting and binging, and to decrease the binging behavior, one has to decrease the restricting. And that could be the actual physical restriction, that could be mental restriction, if there's really rigid food rules, and then you're feeling just shame and guilt or deprivation from having to follow those rules. If it's just not eating enough at, various intervals during the day. And so it's not uncommon for someone to come in and be like, I was doing great. I was eating really clean. I was feeling, the best I've ever felt, but now I'm feeling out of control. And I just need to go back to how I was feeling. And so providing a lot of psychoeducation around if we really want to feel the best and decrease the behavior that's causing distress, we're going to have to look at kind of the whole picture. There might be some negative impact, if it's causing relational conflict, um, impact kind of in job performance, where you might be able to get some buy-in or motivation, and that's where kind of the initial shared goal starts. And as a provider, I always share, right, that my priority is their safety and well-being. And so I'm going to hold that the long-term goal is to decrease eating disorder behavior. And I want to meet them where they're at and where they're willing to work with me to make those kind of 1 degree shifts of change. Just the importance of kind of the ongoing assessment of risk with the outpatient client that I worked with. And we had talked about a higher level of care referral and when that would happen. She did get, she went to urgent care kind of 1 month into our treatment to get another kind of blood work and just physical exam done. Because I really just wanted to make sure that she continued to be medically stable. Um, I think also just assessing or being curious about an individual's purging behavior and how that can sometimes be a form of non-suicidal self-injurious behavior. I worked with an individual where, we were able to develop this shared understanding that her binging and purging was very much a form of self-punishment. And with that kind of shared understanding, developing kind of a coping plan for afterwards and kind of showing herself self-compassion and care, as well as then like how can we generalize that to like other times, so that you're not just showing yourself care after in some ways being very violent toward yourself, and really then kind of conceptualizing the relationship with the eating disorder as an abusive relationship and breaking that cycle. This is just, this comes from the Opal Food and Body Wisdom Disorder Treatment Center. This is kind of the nutritional goals. Um, I think this is just a really helpful visual of recognizing too that not everybody has access to dietitians, but it's very common for individuals to come in and be really tired and really want to just be able to eat without cognitive or physical distress. And while food freedom or intuitive eating are wonderful long-term goals, it's often an unrealistic kind of initial goal, that for kind of like if someone is engaged in chronic dieting behavior, um, our satiety and hunger cues go offline. And so part of the kind of treatment then is really increasing kind of that body trust and body connection, but we need those appetite cues to return. And so mechanical or sometimes robotic eating needs to happen. So early on in treatment, I've worked with individuals where it's, okay, the goal is to increase regularity of eating. And so your alarm on your phone, we're going to set it to go off every 4 hours as a reminder that you need to eat something. And that some of the GI distress that people might report, that the eating disorder voice can reinforce of, see, like I shouldn't be, like I'm eating too much. The GI distress, the bloating, the constipation, all of that is a normal response of a system kind of coming back online. Um, and as you can see, this kind of just goes through that as kind of certain goals are met, then the challenges also change. So initially in treatment, that physical discomfort and emotional reaction to food and challenging those cognitive distortions, or food rules, part of then the work done in therapy is really kind of thinking about how do we tolerate those uncomfortable or overwhelming feelings or sensory experiences that we're having in our body, while still making sure that we're taking care of ourselves. What does a meal or snack look like? What are some of the food exposures that we need to work toward? Recognizing that we're not doing this all at once, because this can, or like, we're not trying to completely overwhelm or drown somebody, but really thinking about kind of that initial managing physical discomfort and emotional reaction to food, creating some structure or schedule around a regular pattern of eating. And then as we kind of work on that, really then thinking about kind of what are the food fears, what are those food rules that are limiting you, how can we begin to kind of self-initiate those food challenges, um, and as how can we continue to build that kind of body trust as you're consistently kind of eating. So your body then is like, okay, like you're going to feed me again. I don't have to kind of send alarm bells or not know when, react as if I don't know when I'm going to get my next, meal or snack. And I think this can just be helpful to look at, especially if you don't have access, or if the client doesn't have access to a dietitian, of kind of some structure of where does kind of the focus of kind of the food fit into kind of the therapy process. We'll start with kind of going over some theory and interventions. So as I mentioned, kind of my foundation and groundwork is in attachment framework and interpersonal process. And so really thinking about, everybody develops an internal working model, thinking about, exploring what is an individual's expectations about themselves or beliefs about themselves. Does someone view themselves as worthy or unworthy, lovable or unlovable? What were their experiences with others? And at this point, how do they view others? Are others trustworthy or reliable or to be kind of feared and kind of kept at arm's length? Have they learned that they really just need to do everything on their own? Is the world safe or a place where, again, like needing to retreat or isolate? How was this individual's relational needs met growing up? And how did they see that modeled? Interpersonal process therapy posits that eating disorders occur within the social and interpersonal context, and that the maintenance of the disorder or even the response to treatment is going to be impacted by important relationships. That's going to be important relationships that the individual has with, on the outside. That's going to be the relationship the individual has with themselves, the relationship that the individual has with you as the provider, and the relationship that they have with the eating disorder. And that if we can understand and conceptualize that the behaviors are occurring as a function to meet relational needs, I have found that that can be a helpful place to, one, have compassion and empathy of, let's honor that. Like, you have figured out a way for this time period of your life, could be years, that this has kept you safe in some way. This has met some unmet relational need, and we need to honor that before we change that. Of course, there's going to be some defensiveness if I'm telling someone or encouraging someone to basically let go of their security blanket. And so if we can develop a shared understanding of how is this behavior meeting an unmet need, what else can we do to meet that need, while also recognizing that whatever you replace that behavior with that is healthier, likely won't have that same immediate kind of impact. And that is something that, with repetition and positive reinforcement can slowly change and make the eating disorder behavior less desirable. More awareness that the behavior isn't meeting the relational need in the way that they thought. I think I'll often sometimes even kind of explore just from a self-determination theory perspective of, how is this helping this person feel a sense of control or autonomy over their life, a sense of mastery, a sense of belonging? Is this behavior that they're engaging in, is this a way to, maintain a close relationship with an important caregiver in their life? Recognizing that it's not uncommon for some individuals to have parents that have their own disordered relationship with food, and that this can be something that they have bonded or connected over. This just goes over kind of the expanded kind of model for eating disorders and looking at the role of individual vulnerability factors. And as the provider and working with the individual, really spending some time at the beginning of treatment, exploring kind of what the interpersonal problem or like focus is. And so is the individual experiencing a lack of intimacy, disconnection, really exploring kind of the social support and how they've either gotten those relational needs met, or like what are the unmet relational needs, and then how does then it make sense that yes, you are engaging in this to feel something. What are where are the interpersonal role disputes? What, like, if it's either a covert or overt conflict that's happening in an important relationship, but also just exploring broadly kind of the family culture and family dynamics, specifically around food and eating and body image. What were those messages growing up? Thinking about the presence of role transitions when you're meeting with the individual, are they currently navigating, a life change, a new job, a new child, a new relationship, recognizing that while these can be, good stressors, that these can also be areas of vulnerability for relapse. Or for kind of worsening eating disorder behavior if someone is actively struggling with an eating disorder, recognizing where there might be grief, either with a loss of a relationship, either through death or a loss of a relationship that an eating disorder may have interfered with, and also recognizing that there can be a lot of complicated grief as the individual is struggling with choosing or engaging in recovery and letting go of the eating disorder. We'll talk in a little bit about how it can often be helpful to kind of make the eating disorder voice its separate entity. And I've had some individuals really describe their eating disorder as their only lifelong friend, the thing that has made them feel safe and valued. And so, of course, there is going to be feelings of grief if this individual is choosing to kind of tip their toes in recovery of what does that mean then to let go of my only lifelong friend where I have felt valued. There's going to be complicated grief there. Thinking about through like life goals and values and how, like the eating disorders can interfere with future life plans and how is like the kind of the cost and benefits of maintaining this eating disorder, or I'll sometimes just start using the language that the person is using. So maintaining this friendship that you have, while it feels good maybe in the moment because it's familiar, how is this interfering with your lifelong goals of starting a family? And sometimes, this can be referred to as you can, maintaining the eating disorder, you're basically choosing to live your life kind of in this grayscale, and choosing to kind of dip your toes in recovery, fully engage in it. It's really scary, totally out of one's comfort zone. It's going to be overwhelming, which is where emotion regulation and grounding is really important. But you're giving yourself the opportunity to really think about living a life in very vivid, full color, or understanding, eating disorder behaviors as a way to manage unmet relational needs, or meet relational needs. I want to invite you to consider your case again. And again, this can be somebody that you've worked with previously or someone that you're working with now. But how do you view the individual's eating disorder behavior helping meet a relational need? Eating can be, very self-soothing and can be very emotionally regulating. Um, and recognizing that that inherently is not a problematic thing. Emotional eating, it's called comfort food for a reason. If we're thinking about if we've had a bad day and if it's your grandmother used to make, cinnamon toast with white toast and butter and cinnamon and sugar, and that provides a sense of comfort. And recognizing when, if we don't have other tools to feel that sense of comfort or to self-soothe, it becomes problematic. Supporting olfactory hallucinations connected to a trauma, so maintaining that kind of connection. And so thinking about the role of clinician in an outpatient setting, and from like an IPT framework, but really kind of exploring and leaning into the ongoing opportunities for providing corrective emotional experiences. Della's very good at this because she will just provide affection and empathy just in her eyes. Um, and then co-creating an environment where honesty and transparency is responded to with compassion and curiosity. And so I think what I have found is that individuals who, experience ambivalence around recovery, which in my experience is most people, no matter how motivated they are, the pull of the eating disorder is very strong. That there might be some hesitation to share if they've engaged in eating disorder behaviors. And so really wanting to, again, to establish very early on, kind of in that guideline conversation, that I am going to be honest and transparent with them. And I invite them and encourage them to be honest and transparent with me. Um, and that allows me to better be able to help them. Because if I don't know if they're struggling with something, I don't like, how are we going to spend our time in a most valuable and effective way? And so this recently came up where I have been working with an individual for about a year now, and she, initially was sharing that one of her food rules for your food was liquid calories. That she was convinced that liquid calories would make her gain weight, and so she was not enjoying the things that she wanted to enjoy. So no coffee dates with friends because she wasn't able, or not enjoyable coffee dates because she wasn't ordering what she wanted. Um, no milkshakes in the summer, smoothies, things like that. And so we worked for a while, and she was ready to kind of start initiating some of these food exposures. And she came in and shared with me that she had ordered a smoothie, and that she was proud of herself, but that also she ended up engaging in a subjective binge later. And so this just reinforced that like this, liquid calories just are not going to fit within her meal plan. And so, I celebrated that, okay, you did the thing, you ordered a smoothie, you haven't done this in years. Um, Before we explore or process the subjective binge, tell me more about the experience of ordering the smoothie. What was that like? What did you order? And she ends up sharing that she ordered a smoothie, but she had replaced it like with everything. So she ended up ordering crushed ice and strawberries, which on a hot day, like that sounds like a refreshing drink, but I don't know if I would call it a snack or a meal replacement. And so when she then felt hungry, not too long after having this drink that she ordered, that caused her a lot of anxiety. And it felt like, well, it wasn't time to eat again. She shouldn't feel hungry. She just had liquid calories. And so she ended up delaying eating and then was even hungrier and ended up engaging in a more subjective binge where she felt very out of control with eating, but also was having a hard time even checking in with herself about what would feel satisfying or filling. And so we were able to kind of explore, like, yes, the subjective binge is distressing, but that wasn't the primary eating disorder behavior that she engaged in. That it sounds like in lots of ways, the eating disorder ordered the smoothie. She didn't order the smoothie. And so what would it be like to go back as her and really think about what she wanted in the smoothie or what she would like to try in a smoothie? Um, and then see kind of tolerate the discomfort of feeling full after an actual satisfying smoothie and check in with herself then. And so, inviting her to actually share, like being curious about someone's experience when they're engaging in a food exposure. I kind of go back to like, I really want it like in a vivid, I want the whole experience to be able to process with the client, to celebrate, to identify what were the challenges, to identify the strengths, what went well, but also then in instances to identify, well, it sounds like the eating disorder was driving the bus in that moment. And let's try this again, and I can respond with that compassion and curiosity. Because I have found at times an individual may not share that they're engaging, out of concern of not wanting to disappoint you as the provider, not wanting to get in trouble, or like the eating disorder is really driving the bus. And, you know, quasi recovery is often a phrase used of, well, I'm doing enough and it looks like I'm engaging in recovery, and the eating disorder is also getting fed in some ways. And so I think that you can offer that compassion and curiosity and hold the client or hold the eating disorder accountable. Um, I think in the ongoing opportunities for providing corrective emotional experiences, um, thinking about the same client with the smoothie, she had an experience, some of the kind of family culture and dynamics that we explored was recognizing that, growing up she was the unidentified patient. Her younger sibling was diagnosed with pediatric cancer and engaged in treatment. So you can imagine a lot of cognitive and emotional and physical energy went toward making sure that her younger sibling was healthy and good. She began engaging in her eating disorder, binging, purging, restricting, as a form of trying to establish a sense of control, to kind of manage her feelings related to her siblings' diagnosis and prognosis, as well as navigating her first romantic relationship that wasn't very healthy, all in the midst of COVID. And so when she initially reached out for help, she went to her parents, and her parents were in a place of, I don't understand that. Like, just eat your lunch. Your sibling is navigating this life and death situation. Like, just get over it. Um, and so, internalizing this of like, okay, like I'm not sick enough for help. I'm not, like this is just something that I need to figure out on my own. And so as an adult, when she connected, she decided to share with her mom that like she had engaged in treatment and she was seeing the benefit and she was noticing just some relief, some more food flexibility, and was really hurt in the very kind of dismissive response that she still received of like not understanding this. Like this is not visible in the way that her sibling's condition was visible. And like, how is this still a thing that you're dealing with? And so in our time together, then really being able to provide kind of that validation of this is like your physical, cognitive, emotional struggle around food and body is real, and it's taking up so much of your headspace, impacting your quality of life and relationships, even if it's invisible to some of the most important people in your life. And there's going to be grief there because you want your mom to be able to respond, and just recognizing that she does not have the capacity to be the support person that you need in this area. Um, and so again, as you can see, like I really explore kind of the family culture and dynamics and how that's then impacting one's relationship with self and their self-treatment, and ways then that are 45 to 50 minutes, if it's once a week or every other week, can we start to shift that self-treatment? Um, so a body timeline is something that I often do in the first phase of treatment after some initial rapport is established, but I think this can also be a great way to assess and gather further information. I often present it to a client as a living document. So it's something that you can bring out session after session. You don't have to complete it in one session, but we'll often just have like some paper available, some colored pencils and markers, and invite somebody to think about their relationship with their body, kind of chronologically. And when some example, like just open questions. When did they first become aware of their body? What messages did they hear about their body or other bodies growing up? And again, just really kind of creating a space of kind of that curious, compassionate exploration of, oh, this makes sense. Because the reality is there can also be so much shame and guilt for engaging in the eating disorder behavior. And so if we can foster some self-compassion around you're taking care of yourself in the best way that you know how. And so part of our treatment is then honoring that and then identifying what are healthier ways. Um, Once a body timeline is complete, it can also be a helpful exercise to then have the individual write a letter to their younger self about thinking about the messages that they did receive. What would they want their younger self to have learned about their body, their value, their worth instead? And so that can be a helpful intervention after that is complete. And so I want to invite all of you either to engage as yourself or thinking about the case that you kind of chose at the beginning. Because I think it can be helpful to think about if I'm asking somebody these questions, have I thought about these questions for myself? And so, again, you can answer this as yourself. You can answer this based on the work that you've done with your client. But just taking a moment to think about what messages did you or your client hear about their body or other bodies growing up? And then also just, right, how might that impact then how they show up in the world and how they might treat themselves? The body image spectrum, this comes from a workbook that is available online that I have a link to that I can share. But I've also used this with individuals in the past to just get a sense of, where they might fall, recognizing that body image is a multidimensional and very dynamic construct that, develops and changes over one's life and can be very much influenced by family. Kind of that earlier family culture can be influenced by peers, romantic relationships, and our culture. And so I'll sometimes, invite somebody to kind of think about where they fall most often on the spectrum, recognizing that body image really encompasses how one perceives themselves, feels about themselves, thinks about their body, as well as then how they view their overall body shape, size, and weight. Perceived physical attractiveness, and then emotions associated with the experience of being in their body. And so this is the spectrum, and then recognizing that everybody has different definitions of these things. The authors share these definitions of what kind of the body respect, body acceptance, body appreciation, body peace, body confidence, and liberation means. I think it's really important to recognize that we can have our own definitions. And so if I'm using this with an individual, I'll share these kind of definitions, but I'll also invite, like, we can create our own shared definitions of, like, what does it mean to respect your body? What does it mean to accept your body? What does it mean to appreciate your body or experience body peace? What would it mean to feel more confident in your body? Or what would it mean to really kind of feel liberated in your body? Again, so I invite you to engage in the body image spectrum. So again, you can participate as yourself, or you can participate as where you imagine if you were to offer this to a client, where your client would put themselves. Some other questions, and this is all kind of part of the body image workbook, but some other kind of open-ended questions that I think can be helpful to talk about with an individual is just what is it even like to look at the spectrum, recognizing that the way that we feel about ourselves, perceive ourselves, think about ourselves, that is going to fluctuate on a day-to-day and sometimes on an hour-to-hour basis. but that our body itself doesn't actually change that much on a day-to-day basis. And so what would even just kind of that knowledge, I think can be really important to kind of normalize and validate that our feelings about ourselves and our body can change and fluctuate sometimes wildly based on the kind of day that one might be having. Um, but that our body doesn't actually change. Our body is on that day-to-day basis. And the constant in life is that our bodies are always changing, which can be overwhelming, I think, for some individuals to hear or sit with. But I'll sometimes invite an individual to think about, okay, so here's, what these authors have kind of put on the spectrum. Are there things that you would add or change that if these don't capture your experience of your body? And then thinking about where you might be today or where you're most often right now, where would you like to be? And if we're even just thinking about moving up, just one kind of aspect on the spectrum, what would need to change to feel a little bit more body respect? What could be a way to show your body respect? And also just then inviting a conversation that might just start with like, well, let's look at like your sleep hygiene. Regular sleep is a way to show your body respect. Are there ways to show your body respect almost in a external way to then slowly start to increase a more kind of sense of internal body respect? I often will explore too if there's somebody in their life where like is there somebody in their life that can be a role model, and not like in a I want to look like this person, but is there somebody in their life that is a role model of more, flexibility or freedom around body image and eating. Someone who maybe is closer to that body confidence or body liberation, or in some ways, I'm not like smashing kind of societal ideals. That's not always present in somebody's life, but I think it can be useful to explore if there's somebody that they can look up to. And in some ways, even if that person is in their vicinity, sometimes engaging in body doubling, and having that, like going out to eat with that person or just spending time with that person can be a helpful way of increasing support. So we're going to transition a little bit to talking about acceptance and commitment therapy specifically for eating disorders. And so this is an evidence-based treatment for eating disorders. Again, as I mentioned in the beginning, there are many other evidence-based treatments that I will not be talking about today. And I'm not trying to say that one is better than the other, really just talking about different interventions that you can use. And so the primary goal of ACT is to increase psychological flexibility. And as you can imagine, someone who is actively engaged in an eating disorder is not going to have a lot of psychological flexibility. As someone mentioned earlier, there's a lot of rigidity around those cognitive distortions, body image distortions, and internalized beliefs. And so thinking about kind of these 6 tenets of ACT, kind of that acceptance, radical acceptance piece, this can be really hard at first because this is about kind of the willingness and ability to tolerate difficult thoughts or emotions, and recognizing and exploring with an individual how their eating disorder behavior can be a way to numb. And so why there might be a perceived benefit of, well, I won't feel the negative feeling. There's also this dullness of, and you won't really have full access to other feelings, joy, connection. Um, and, then the goal is, can we increase confidence in the ability to experience and tolerate those uncomfortable thoughts and feelings? And maybe in the beginning, right, that's just in the 45 minutes that you have with them in session. Are we able to sit with and acknowledge that there's some anger or grief or disappointment or rejection that is hard to sit with? I don't know many people who like to sit with those emotions or acknowledge or process. The cognitive diffusion I have found really helpful in work with eating disorders. And so this is the kind of idea of creating an intentional space from thoughts and feelings. And so that empowering the individual that they're in charge of the volume. And we'll dive into this in a little bit, but I have found that this can sometimes be less, this can require less cognitive energy than engaging in like active reframing or positive affirmations, especially when feeling triggered or activated. Being present, again, I think is challenging and is a really helpful skill to build in terms of just being like in the here and now and being where your feet are and acknowledging your experience in the moment. The self is context, again, just being able to notice your thoughts and not have your thoughts or your eating disorder in lots of ways like drive the bus. And then really exploring with the individual what their values are, what is important to them, and how is your eating disorder either allowing you to live in alignment with your values or not in alignment with your values. And so often I have found that like if an individual has value of like connection, community, family, there can be some kind of motivational interviewing buy-in about how the eating disorder is actually a barrier to living more in alignment with their values. Um, I have used the phrase before with an individual that let like if their value is like connection, family, friends, time with loved ones, that it's actually healthier to eat ice cream with a friend or a family member than broccoli alone. And again, right, there's nuance. You can't eat ice cream every day for every meal, but that there's a lot of research on loneliness and the impact on cardiovascular health, and just recognizing how isolating eating disorders can be, that if you're invited out, it is actually healthier to go and be able to connect and celebrate. And maybe food, you know, as part of recovery, food becomes less of the focus, but to just be able to be present and enjoy that moment with a loved one. And then thinking about, you know, what are the things that are important to this individual and how is the eating disorder helping you pursue those things or hurting you in pursuing those things? And so thinking about implementing cognitive diffusion. And so the goal is to really shift attention away from the content of the thoughts and really just kind of being able to look at the process of thinking. And I have found that it has been helpful in if somebody is triggered or activated, they're often then kind of in this hypervigilant fight, flight, or freeze state. And so in those moments, it can be hard to access kind of reframing or a positive affirmation. And it can feel more accessible of, can we just increase some space? And so as we think about an individual gets triggered, and so kind of just walking through an example, somebody sees a photo of themselves that they feel like is not very flattering and they start to really nitpick at it. This can spike their anxiety, worsen their mood, and the thoughts can become very one-sided and extreme and very loud. So it can be hard to really take perspective. Um, I have had individuals describe themselves in photos as, you know, I am gross, I am disgusting, I am boxy. And you can hear in that the themes of both kind of the extreme kind of overwhelming feeling, but also this sensory experience of being in one's body that feels overwhelming and uncomfortable for a host of reasons. So kind of wanting to like get out of their body. And then, you know, following that, it's very easy to kind of get lost in this thought. And so if you kind of take this example of somebody sees a photo of themselves, let's say they took a break on social media and were scrolling and saw a friend post themselves, all of a sudden it's really hard to then refocus or reshift to whatever they were doing or to be kind of in the moment if they were kind of at a social kind of setting to want to connect. Oftentimes, when someone is experiencing kind of a fusion in thoughts and feeling triggered, they want to isolate and really engage with the eating disorder. And so a couple different kind of thought distancing or cognitive diffusion examples. I originally had this on a PowerPoint and it was nice because I was able to do the animations. But the first one is I will often have an individual take a repetitive triggering thought that they have. Um, and so this could be like I am gross, and I need to act on that immediately. My eating disorder is telling me that I need to, um, skip lunch or avoid going out, and I'm going to eat by myself. And so if I have, like, sometimes I've had a whiteboard in my office, sometimes I'll just have an individual take a piece of paper and if I don't have a visual, I'll literally kind of use my hand and my face with the idea that the initial thought is, I am gross. It's like right here. You can't see anything out of that. You can't do anything with that. You have to, it feels like urgent and you have to act on that thought to then putting the stem in front of that of I am having the thought that I am gross. Even just labeling this is like, this is just a thought. It doesn't make it true. It doesn't mean that I need to respond to it immediately. It's an uncomfortable thought. It's going to cause some uncomfortable feelings. And maybe like I kind of just, having a creepy crawly sense in my skin, but like I've got some space to then I am noticing that I'm having the thought that I am gross. So creating even more distance between that initial thought and yourself, kind of that eating disorder voice and yourself. Because at times, right, it can just feel very enmeshed. And so then with that space, then that gives us a little bit of time to think about, okay, do I want to continue to engage with this thought? Can I put this just over here? And if in 15 minutes I'm still feeling that way, maybe I can revisit that. Or is there something else that I can do right now to take care of myself that I know when I've had this thought in the past has made me feel a little bit better? Is it possible for me to just change my clothes and just get more comfortable? And so oftentimes I'll have the individual will come up kind of with a list of some of those repetitive triggering thoughts and on index cards, kind of write this out so that they have that visual cue as a reminder when they leave the office. I think another example would be naming the story. And so again, just thinking of repetitive thoughts as familiar stories, and then just being able to name it as that story. If it's the I'm unlovable story, the I'm a failure story, I'm gross story, and then intentionally practicing like, okay, once I name it, I'm not going to give it more attention. I'm not going to write another chapter. I can even visualize like I'm going to close the book. I might not know what other book or story to pick up, but I'm just going to imagine closing the book. I think it can also be really helpful to really differentiate and separate the eating disorder voice from the individual. And so just validating that eating disorders are going to have lots of repetitive stories. I don't deserve to eat. I need to work out today to earn my food. My eating disorder is in charge. I am only worthy if I will start over again tomorrow. It can go on and on and on in this very vicious cycle. And so some individuals have found that just naming the eating disorder voice can be a helpful first step of getting some separation. I also have found it really helpful to explore with the individual if that eating disorder thought, voice, kind of internal belief, if that sounds like someone they know. Does it sound like a caregiver that they've had in the past? Does it sound like another important relationship? Is the treatment or behavior that the person is engaging in? Is the individual, is the patient still acting like that caregiver or important person is in charge? Is that helpful or harmful for them? Is that individual treating themselves like they were treated by that individual? Is that helpful or harmful for them? And so again, just creating a space for a lot of curiosity and exploration, because without it's really hard to change without having a sense of what is driving this and how has this functioned for you. And it's really scary to change if we're basically in the dark and then going to another place that feels even more in the dark, but it's an unfamiliar darkness. Um, Another helpful skill building technique is urge surfing. This can be um, really helpful specifically for binging and purging. This is really going to kind of thinking about the tenets of ACT. This is really having someone practice kind of that radical acceptance of uncomfortable thoughts and emotions and being very present with their experience. And so it's the practice of noticing that you have an urge to engage in eating disorder behaviors. And this is often described, especially like with the binging and purging, that there's no control. I just like it was this compulsive need. And some people, may even describe blacking out until the binge and purge is over. And so recognizing that urges are part of the human experience, they will occur. And an urge is going to have this buildup, a peak, and the runoff. But what typically happens is that an individual is going to respond to the urge at its peak. So the urge goes away, but the individual doesn't have the experience that the urge does dissipate over time, nor do they have the confidence that they're able to tolerate the urge because they're engaging with it at the peak. And so it can be helpful to there's lots of different kind of handouts, but really thinking about kind of the analogy of an ocean wave, and that to urge surf, you're really just riding the wave through delay, distract, and decide. And so I'll often start with just recommending someone to set a timer on their phone. I have worked with an individual where we have started with 1 minute, with the goal of for 1 minute to not respond to the urge and to check in with yourself then at the end of 1 minute, like how is that urge feeling? How are you feeling? Do you think you could go for another minute? Is there something that you can do to distract yourself? And all really lean into, if you can set your timer for 1 minute and then you decide to engage in the urge, that's still different because for 1 minute, you didn't. You're already creating some space. You already sat for 1 minute in the very uncomfortable, very, in some ways, like overstimulating experience of having this very strong urge. And so next time, can we try for 2 minutes, for 5 minutes, for 15 minutes? It can be really helpful to really identify in session with an individual, what are they going to do in that distraction time? So if somebody sets a timer for 15 minutes, it's really hard to just look at a timer coming down for 15 minutes when that urge is really loud. And so coming up with a variety of different things that they can engage in, that again, they have written down, there's a visual cue, so they don't have to do extra, they don't have to expend extra cognitive energy when they're feeling distressed. I have found for some individuals, it's really helpful to kind of brainstorm and think about what are activities that keep their hands busy. Is that, I've had one individual, is it painting nails? Is it taking a cold shower and kind of using, just that temperature and kind of washing your body, putting lotion on, and then checking in with yourself and kind of seeing where that urge is? Is that knitting or crocheting, is that sometimes it's helpful for individuals just to change the environment. Are we able to get out of the room that you're in, take a walk around the block, take a walk up and down the stairwell, and then come back and decide when that timer goes off, what do you what would you like to do? And really kind of talking about like if somebody decides to engage in that urge at the end of the 15 minutes, there's no shame in that. We're working on building a skill. So if you don't experience, complete remission over, after one rep, like that makes total sense. Most people don't experience success after doing one thing one time. And so that this is just part of kind of a building block and building confidence. Sometimes if somebody has like, again, and this can be, some of the handouts are really helpful at this with the decision point, even if it's kind of prompting the individual to reflect on what are the pros of engaging in the urge, what are the cons or cost of engaging in the urge, are there reasons that I don't want to engage? What are my larger life goals? Kind of that kind of values alignment piece. Does this urge take me closer to my values or further away from my values? But again, I think it really just depends on kind of where your client's at. And so sometimes it can be helpful to have kind of a visual, like here are some questions that I need to engage in to make that decision. And sometimes, but I think it's most helpful to really just start about like with brainstorming, what are my healthy distraction techniques? As I mentioned, and I think I've kind of integrated this kind of throughout today's talk, but I think self-compassion is just was so helpful for everyone, and being able to integrate it into the treatment of eating disorders, especially around just the like the shame and guilt that somebody can feel for having an eating disorder, for engaging with the behavior, for the loss of relationships, for the negative impact. I've had many individuals, come to me after years of struggling of, society views this as such a superficial issue or vain issue, and I'm not a vain or superficial person, and like this just is not in alignment, and there can just be so much shame. Like I don't want to have these thoughts or feelings. And so, again, kind of introducing the elements of self-compassion and the importance of self-kindness, especially when we are feeling like a failure, when we're suffering, when we're in pain, when we're feeling inadequate, and how showing your self-kindness in those moments can help interrupt shame spirals, but also just recognizing that that can be totally new and different from what was modeled or given to them growing up. And then even what what they're currently doing or seeing in their peer group relationships. And so it can be completely out of somebody's comfort zone. This sense of common humanity versus isolation, just recognizing that eating disorders are so isolating, and that it can feel at times that the individual is alone with their painful experience, and recognizing that there are ways that kind of that pain and suffering can be very connecting, and that an individual doesn't have to suffer alone, as well as then this, mindfulness and kind of being present focused versus more of that fusion with thoughts or over identification with thoughts. And so these exercises come from Kristen Neff's Self-Compassion website. It's a wonderful resource. She's got a lot of different audio guides, a lot of different kind of handouts for clients and clinicians to utilize. I have also found that utilizing a picture of one's younger self can be helpful in navigating triggers and maintaining motivation. Specifically, can often be helpful kind of with accountability at meal times. And so I'll often invite an individual to choose a photo of their younger self. And if that is too painful or challenging, I'll invite them to select a picture of if they have a younger family member, sibling, niece, nephew, cousin, but a picture of it, a younger child, and really like pulling out that picture when they have to engage in a recovery behavior, if that's eating, a meal or engaging in a food exposure or fear food. Um, and thinking about what messages would you want this child to be surrounded by? Um, how is engaging in this recovery focused action helping this younger child receive the care, love, compassion that maybe they didn't get to receive growing up? And in lots of ways, yeah, just showing attention kind of to our inner child and treating kind of the younger self with that care and compassion. And that is at times going to be through nourishment. And it might be nourishment with food that you grew up feeling or believing was not nourishment. This quote from Tina Fey is from her book Bossy Pants, which was published in 2011. And I think looking through this quote, that was almost 15 years ago. And if anything, I think it has just become more pronounced that there are just so many different competing, contradictory messages around what is healthy, what is normal, what is wellness versus what is diet culture. And just wanting to share this to, I think, acknowledge just this is the water that we're all navigating. And I think it can be then especially difficult for somebody recovering from an eating disorder to even like be able to come up with a clear answer or definition of what is healthy and normal when the reality is oftentimes what is going to be healthy is going to be very counterculture to what is currently in some way what has always been in the water. I have found that it's really, and I talked a little bit about this kind of in the assessment training in December, but really getting a sense of what messages the individual is currently consuming. What are they surrounded by, and getting a sense of how much time they're spending on social media. What does their For You page look like? How do they feel after spending time on social media? What accounts are they following? What side of the algorithm are they on? And recognizing that eating disorders are very shape-shifting. And so being very mindful and aware that so I'm currently working with an individual who came in with a history of restriction and binging and purging. And she, is reporting feeling, significantly more food freedom and flexibility. But she's also become very hyper focused on the number of grams of protein that she's eating each day and making sure that she's engaged in strength training a certain amount of times per week. And I want to be really clear, right? I don't think there's anything inherently problematic with strength training or inherently problematic with making sure that you're getting enough protein, adequate protein, and being really curious with her about how is this just your eating disorder wearing a different costume? Because, over the past 2 months, like you're, eating a chocolate protein bar when you want a brownie. So maybe you're getting some fix of chocolate, but is that really satisfying? Like maybe there are times where that makes sense because you're in a rush and you need something that is just more won't maybe give you the sugar crash that a brownie will give you, but does the brownie flavored protein bar, every day for your afternoon snack, is that really healthy, or is that just a different kind of rigidity that you're falling into? There was a lot of work done on decreasing the calorie counting, which is great, and I'm happy to hear that that's not happening. And I'm concerned and a little curious about like what is the function of the counting of the protein grams? Is that hopeful? Is that harmful? What happens on a day when like you just want some pasta for dinner? Um, are you able to do that? So let's be curious, like how, yes, there you have increased some flexibility, you're doing some things differently. And let's just be aware of where the eating disorder might be lurking in the shadows. Um, and so I think just the ongoing assessment, and being curious about a person's experience as they're, engaging in food exposures or trying new things, that it's not, I think I heard a phrase earlier, that the kind of eating disorder to it's wellness culture or gym girly or bodybuilding pipeline is I think is very real in that that can be a very socially appropriate kind of celebrated way, and externally objectively or people view that as in some ways there can be a lot of morality around what is morally good and morally not good, and yeah, I could go off on a whole tangent, but I won't. But I just wanting to really acknowledge kind of diet culture and wellness culture and the commodification of it and the amount of money that people can spend to look and feel better. And also being then curious about, hey, if you're spending money on, I had a client once who was spending a significant amount of money on muscle eggs, which was something that was popular at the time in the bodybuilding world, and it had more protein than regular eggs. Um, is this like, is there something else that you would want to be spending your money on, or would be more in alignment with your values or desire to kind of travel and see the world? And are there ways that we can shift away from that? These are some helpful resources that I often use with clients. The Body is Not an Apology also has a workbook. So you can kind of read the book and have the workbook, do the workbook at the same time with your individuals. Body Kindness is by a dietitian, and it's a lot about kind of that countercultural, anti-diet culture approach and food flexibility and food freedom and living with your body and other things you hate, has some wonderful kind of interventions and discussions specifically around body image. And then the Courage to Nourish Body Image workbook, that's the link to the body image spectrum. And I'll make sure to save or to share that with you all so you have access to that. These are some really helpful social media accounts. So I'll often do an assessment with individuals about like what are they seeing on social media. These are Instagram handles, but most of these individuals also have TikTok pages with the same handle. And so for clients, this is a mix of dietitians and mental health professionals, as well as a food scientist who does a lot of really good videos on debunking some of the wellness culture, food demonization that is very prevalent right now. And so I have found, right, that maybe it's not realistic to completely delete social media for a time, but are there ways that we can add some more helpful accounts? So even as you are scrolling, can you have a message that is more affirming of recovery? And then Therapy with Mar is a page that I have found is very helpful for clinicians. She's got a lot of wonderful resources. And then this is one of my favorite quotes about recovery. I am unable to find who originally said this. So if anyone knows, please let me know. And I would love to be able to credit the original person who shared this, but just that recovery is not a destination where one day you will wake up and feel fixed, but rather it is a slow mending process that follows an imperfect line where progress is made over time. Along the way, your eating disorder will make its presence known as it fluctuates between being very quiet or very loud, and use this as reassurance that you are healing by the mere fact that you are aware of the sound it makes and in charge of the volume. I've often spoken with individuals too about, and this can be a controversial intervention or take, but I think applying some harm reduction principles from the kind of the substance use world can be really applicable in eating disorder recovery. And I sometimes have spoken with individuals where it's like, you have tried everything, right? And you are really struggling. And like your quality of life, you like are like it's not where you want it to be. And so, what if we just experimented? What if we just gave recovery a try with almost this like free pass of, and if you really hate it, like you can always go back to your eating disorder. Like that, like you have autonomy and free will and choice. But this is like the one thing that you haven't yet given yourself the opportunity to really engage with. And so let's just experiment. Um, I've sometimes done this with individuals who will break it down to even like more like day by day segments of I had an individual I was working with who was able to, when she went on vacation, it was like freedom from her eating disorder, and she could just really be present and like enjoy. And so it was like, okay, well, let's choose one day a week where like you go on vacation and you just wake up and you imagine that this is just another travel day. What feels different? How can we implement some of that vacation kind of freedom mentality into your day to day? And so I think, again, just being meeting clients where they're at, but also really honoring their autonomy. And is there a way where can you are deserving and worthy to give yourself the opportunity to try this thing, and you've tried everything else. So it's just one more thing to try. And you're not going to have, an immediate good outcome 24 hours later, but really giving yourself like a fair kind of fighting chance. Um, that is all I have for you today. These are some selected references.